Okay, so good afternoon, everyone. So, a recap, mabuhay. So we're starting this session on male aesthetics. I'm Dr. Sairi Lagan from the Philippines, and I'm here with Doc Irina.
Thank you. Welcome to this interesting session. Where is our first speaker?
And male aesthetics has always been something consistently growing.
Yeah, great. So just wait some.
Yeah, if the speakers can also already sit at front, we would appreciate it. Yeah, male aesthetics has always been really, it's a growing market, right? How
Absolutely.
many percent of your patients are male?
In my country, not too many.
Not
But
too many.
anyway, it is growing.
Yeah, my clinic's 55%.
Oh,
So yeah, maybe some of the speakers can also answer that as we go along. But anyway, yeah.
yeah. So, are we going to wait a little bit,
No,
or
we can start. Yeah,
We
because
start.
we're
So,
late already.
it's my pleasure to invite our first speaker, Dr. Johannes Flores Dairit. He will be speak about skin boosters for men. Please, doctor.
Thank you very much. Good afternoon, colleagues. I'll be talking about skin boosters for men in the context of what's new in anti-aging. So I do not have any potential conflict of interest in this presentation. So we define skin boosters and cite the classification. So skin boosters, they slow down the skin aging process. On the molecular level, it improves density and quality of skin cells. It modifies the extracellular matrix, or the CEM, by providing nutrients and providing building blocks and proteins and amino acids. More importantly, it regulates pathways. It is involved in the cross-talking of cells from the epidermis to the dermis and the other cells in the body. And they upregulate and downregulate anti-aging mediators. And more importantly, they also have antioxidant and anti-inflammatory effects. So I did a short research on the level of evidence of skin boosters because they are already like plenty. The market is has many skin boosters. So most of them, they fall in like level 2 or moderate degree of evidence, meaning that randomized controlled trials have been done already. But please take note, there is a type of evidence and findings. So for example, for injectable HAs, only for hydration and skin elasticity, for cross-linked hyaluronic acid microinjections, so collagen stimulation, ECM remodeling. For PLLA, 11 randomized controlled trials for volumization and elasticity, which lasts for more than 25 months. PDRN, many animal studies, mainly for its antioxidant and anti-aging properties. So level 2, which is preclinical. So studies in humans are still lacking, like randomized controlled trials. For HA plus amino acids, glycine, leucine, proline, lysine, 11 studies for collagen neosynthesis, which takes about 4 months to build up or remodel collagen. So why skin boosters are more challenging for men? Well, we all know that we have thicker dermis, more sebaceous glands. We are also prone to develop folliculitis with microinjections because of the presence of more hair. We have deeper wrinkles, we have stronger muscles, and interestingly, we have lower skincare adherence and less photoprotection, which accelerates photoaging. So these are the new aging concepts and molecular pathways, and we ask the question, how do skin boosters contribute to the latest anti-aging breakthroughs? So we now acknowledge that aging occurs in the systemic or systematic level, involves other organs as well, cellular level as well as molecular level. This is from a very interesting publication from 2022. And we are now in the era of what is called xenotherapeutics, which is a class of emerging pharmacological treatments. It targets cellular senescence. So now aging is focused on senescence, which is cell aging. It is triggered by cellular stress. There are changes in gene expression, morphology, metabolism. And basically the problem is the cells survive, they age, but there is decreased apoptosis or programmed cell death. And when there is decreased apoptosis or programmed cell death, there is upregulation of what is called SASPs, or senescence-associated secretory phenotype, which is a major key player, and it needs to be down-regulated if you want to control the aging process. And its accumulation, so if you accumulate a lot of SASPs, it drives chronic inflammation and related to adverse outcomes of infections. So what are the consequences of increased numbers of senescent cells or increased SASPs in tissues and organs? Well, in the skin, chronic inflammation, collagen degeneration, impaired regeneration, and pigmentary changes. It also occurs on the heart with vascular inflammation, atherosclerosis, insulin resistance, metabolic syndrome. So now we can relate, everything is already interrelated. So for xenotherapeutics, we have senolytics versus xenomorphics. The senolytics eliminate aging cells, and these are a class of drugs designed to selectively eliminate aging cells with the following. So we have dasatinib, these are biologics, quercetin, and the other cardiac glycosides, some fruit chemicals or products, fisetin, curcumin, piper plant varieties, right, like your black pepper. So perhaps Ayurveda is correct from the very beginning. So these drugs are being researched for their potential to delay, prevent, or alleviate various age-related conditions as well. In contradistinction, your xenomorphics, they just modulate. They don't try to accelerate apoptosis of these aging cells. So this includes rapamycin, metformin, aspirin, which were discovered by serendipity, azithromycin, fenofibrate, as well as metformin, resveratrol, and some other flavonoids. So now we ask the question, which types of skin boosters, so that we will have evidence that they actually work on the anti-aging process, either act through senolytic or xenomorphic mechanisms, by cellular targets. So we start with xenomorphic agents. I'm sure you have heard a lot of lectures about dermal fibroblasts because they produce and maintain ECM, but they also have like a lot of functions in different organs. They can also be progenitor cells of the, for example, the adipocytes, the pericytes, and the myoblasts in the muscle. Your fibroblasts, they are attached to your collagen. They actually synthesize amino acids and collagen. And for the younger individuals, the collagen is firmly attached to the fibroblast. And then we've heard many lectures about EZM, but now we know that it's dependent on the TGF-beta receptor to prevent breakdown. And these are the pathways that are now being implicated in accelerated aging, PDGF, TGF-beta, as well as the WNT signaling, which is very significant in pigmentary disorders. So what are the skin boosters, ingredients, and rationale for use? This is, I think, a very important slide. This is from a journal with a very high impact factor, and it was published in 2024. So these are the biological macromolecules for tissue regeneration. It includes the following: mostly marine products. It includes your gelatin, as well as collagen and hyaluronic acid. But in recent years, hyaluronic acid is recognized as a xenomorphic, so it modifies the behavior of the skin cells. It could penetrate the stratum corneum through strong skin hydration, so it is hydrating. The higher molecular weight variant is difficult to penetrate the stratum corneum, so sometimes we have to do micro-injections. So it holds molecules, it's responsible for hydration, but it also regenerates elastic fibers, mainly type 1 and also type 3 collagen. It increases adipocytes, bone and muscle vitality and proliferation. So it modifies the pH, sebum, hydration, epidermal growth factor, dermal thickness, thickness of the epithelium, as well as the number of vessels. And histologically, HA produces like thicker and more robust collagen, as well as elastic fibers, which is evident in this elastic Van Giesen stain. So the question is, can hyaluronic acid be considered as a xenomorph? Yes, HA can reduce MMP13 and SASP genes, MMP12 and CXCL9. It may also affect gene expression related to aging, so it has an effect of the mRNA and miRNA. In a very important study, it is topical HA and niacinamide combination, which actually downregulates your SASPs. The next question is, can PLLA, PDRN, PRP be considered as a xenomorph? Yes. Sometimes if you ask ChatGPT or Copilot, they will say otherwise. So I have to review some of the papers, and in the future, please correct me if I'm wrong. But now some of the articles are already available, especially systematic reviews, meta-analysis, and randomized controlled trials. Can collagen and amino acids be considered as a xenomorph? Well, no, but they are recognized as building blocks, and they are involved in the regulation of normal fibroblast activity. And did you know that collagen, when you inject it, or precursors of collagen, they can actually stimulate the growth of a limb? This is a very important paper from Stanford in during the 1980s. So skin booster injection techniques, I don't have to lecture on in detail. So patient selection is very important because you've heard many lectures already. Are pre-existing dermatological conditions stable or treated, like acne, rosacea, metabolic syndrome? Is age proportional to appearance? Do patients appear bony or puffy? If the patients are bony, the goal is volumization. If the patient is puffy, the goal is skin tightening. And this is a slide that I have created based on my readings. So this is evidence-based treatment protocols, so mostly combination treatments, but should be approved by your local FDA. So the xenomorphs include injectable HA, topical HA plus niacinamide, PDRN, PLLA, PRP, and if you use these products, there is a scientific basis that they can exert like xenomorphic activities. However, the endogenous agents are also have been studied very extensively, so that includes exosomes, which are biological messengers, collagen precursors, and endogenous peptides. For the procedure, I like procedures or injections, either with a cannula or with a needle, on the concept of like vectoring. So I usually do this procedure in my clinic. You inject the outer crown for using the vectoring technique, and the inner crown for volumization. But most of the time, the younger patients do better than the older patients. And then mesotherapy, you've heard a lot of lectures on mesotherapy. We're coming out soon with a publication and indicated the very important mesotherapy points. And you can use most of the xenomorphs that I have included. So these are just some clinical cases. So I use the double crown lift using HA plus amino acids in these patients and PDRN in the under eye area. So both are xenomorphic with a level 2 grade of evidence. And of course, if you use a procedure or a product which has a very high level of evidence, you will get results. So these are just some before and after pictures after 1 year. This is from the use of HA, amino acids, PDRN, 3 sessions. This is day 1, day 2, day 14. So you see improvement in skin texture. So this is the use of PLLA on the mid-face for 1 session, MNRF, so micro-needling RF with HA injections on the whole face, 6 sessions with PDRN under eye area. And if you follow up patients in the long term, you will definitely see an effect. And last but not the least, from long-term follow-up of this patient who underwent, because we have a lot of devices now with the micro-needling RF, with injection of non-reticulated HA on the whole face, 6 sessions or more, with PDRN on the under eye area for 3 years, and definitely you will see an effect. Diminution of superficial wrinkles, as well as improvement in skin quality. So the dermatologist, the aesthetic physician, the plastic surgeon should be able to create a more holistic plan, which do not only address enhancement of facial features, but also consider treatment of skin diseases first, overall skin health, lifestyle, behavior, and rejuvenation goals, utilize injectables with xenomorphic properties. Combination approach is always better than monotherapy. And all of our procedures should be evidence-based and FDA approved. So thank you very much for your attention.
Thank you, Dr. Johan. Very nice presentation. Very interesting that you see the level of evidence, which is very important for us doctors. Anyway, moving on to the next speaker, we have Dr. Fernando Valenzuela. He's a dermatologist from Chile. Welcome.
Good afternoon. Thank you so much for the invitation. And today I will talk about the management of acne in transgender and gender diverse youth. I think it's a topic very interesting for us as physicians because this population is increasing and they really need some help, especially because the appearance of acne, sometimes it's a very complicated way to gain the hormone levels that they need. I don't have any particular conflict of interest now, but I have served participating in many clinical trials in other topics. And let's talk about transgender. We have to know the classification on cisgender and transgender. Cisgender means that a person, it's the same, the gender assessed by birth, and the gender that the patient has in a certain moment. And trans, it means that it's transiting from one gender to the other. So these transgender and gender diverse individuals are growing and they have some particular skin conditions such as acne. And we need to understand that there is an impact because they have to go through some profound endocrinologist and cutaneous changes. And also there's a clinical gap because we don't have a lot of specific guidelines for this population, and we need to integrate not only our medical point of view, but also the gender affirmation principles. When people is transiting to become males, so the trans-masculine population, more than 90% of those persons can develop acne, especially during the first month. And it's important because more than 1% of the US adults are nowadays are identifying as transgender, and 1 to 9% of youth identifies as gender diverse. So acne is one of the complications, but it's treatable, and so we need to understand the gap, the need, and we have to create guidelines for helping those people transiting in the best way possible. When the patient is using testosterone, you know for sure there will be an increase of the sebum production and the possibility of acne. And the peak of the acne is about 4 to 6 months, and it gradually decline through 2 years, but it can last even for 10 years. And it's important because, of course, the patient can suffer from the diminution of quality of life, and the idea, those population is really sensitive, so our goal is to help in the whole transition. For sure, those population has an increased level of testosterone, exogenous testosterone, so they have the DHT because they, as any other person, use the 5-alpha reductase, and so they have an increased amount of DHT binding to the receptors and sebocytes and maximize the proliferation of those sebocytes and producing lipid synthesis and increasing the appearance of acne. But it's not the only factor. Most of those patients are using chest binding in order to cover the breasts, so the occlusion, the friction, and the heat can promote the proliferation of C. acnes and folliculitis. Also, most of those population is using whey protein supplements, and we know that they increase the sebaceous synthesis and developing hyperkeratinization. if a patient start the transformation at younger age, there are more sebaceous glands to be grown, and also if the testosterone levels are above 630 nanograms per deciliter, this is an excessive amount of testosterone, and it's going to lead to more acne. And also, if a patient is acting in smoking, will produce more free radicals, causing the sebocyte dysfunction and impairing of the healing. When we try to do this global approach in acne in this population, we have to think on the guidelines. As I mentioned, there are no really particular guidelines for this population, but we can use like the regular ones with some particular concepts that I will talk later on. We have to coordinate care not only with us dermatologists, but also with endocrinology, psychiatry, and also reproductive health teams. We must use inclusive language, and it's quite important, and we have to reframe the acne and understand that it's not due to a poor hygiene or personal failure. Regarding the gender-affirming language, it's important we don't have to use the birth name or the real name. We have to use the chosen name the patient has chosen or the legal one. Try to avoid, say, male or female patient and state the gender identity. Don't say sex change because it could be something very emotional for the patients. Prefer the pronouns that the patient wants to be. Don't say also biological male or female, and always try these patients with a patient, but also with compassion and explaining all the things that the treatment is going through. If the patient is suffering from mild acne, we can use topical therapy as usual. We can use retinoids, benzoyl peroxide, the topical antibiotics, and the fixed combination without any problem, and we have a lot of experience on this. But if the acne is moderate or severe, we have to escalate using oral antibiotics or isotretinoin. And I will discuss something really important. Transgender male can get pregnant, so we cannot forget this. And when we use isotretinoin, we need to be aware of that, and the patient must understand and use oral contraceptives. And if we detect that the testosterone is really high, we have to coordinate directly with endocrinology to reduce the testosterone levels. This is a particular thing on this population. We cannot use spironolactone because it will block the androgen receptors, and so it will be blocking the transition. So never prescribe spironolactone on this population. And we can use, and sometimes we must use oral contraceptives, especially if we are using oral antibiotics or isotretinoin. But be aware that sometimes the oral contraceptive can increase dysphoria or the breast tenderness, and it's important that the patient to understand and know that it's only for a couple of days. Even if the patient is in a high testosterone level on the body, it's not a contraceptive, and the patient can ovulate, and so we must be aware those patients can be pregnant, and so if we're using tetracyclines or isotretinoin, we must be aware of that. We need to understand that patient can must use contraceptions, and the concealing must be confidential, respectful, and not invasive for the patient. Those populations also are really in danger regarding mental health, so severe acne will carry a really tremendous impact psychologically, and those patients are at least 2 or 3 times more in risk of depression and anxiety. And we know that if a patient is suffering facial or trunk acne, will get more dysphoria and it's going to be worse. And so screen actively if a patient has symptoms or feelings of depression or anxiety, and try to educate the patient that it's not normal to have acne and we can treat it. So at the end of my talk, I would like to point that this is work we have to do together with the endocrinology, mental health specialists, and us as dermatologists, because we know that this population is very sensitive and we can treat acne. They no required to suffer from acne in order to get the transition, and this is something that we must be aware, and it's not complicated at all. And those population really needs us to help them. Thank you so much.
Thank you very much, Doctor. Now it's my pleasure to present my co-chair and also a friend of mine, Dr. Cyril Mitchell-Agan. Please,
Thank you.
just let us know what is
Yeah.
about sexy jowl of the man.
Yes. So, mabuhay, sawadee-kap. I'm Dr. Cyril Lagan from the Philippines. Interestingly, earlier today I had a presentation on transgender female thread lift. We should be in the same session next time, right? Still waiting for the... But anyway, I was mentioning earlier that the number of male patients is really increasing over time. There. Okay? Is working now? Yeah, and it's here. Yeah, and in my clinic, about 55% of my patients are men, and it become like a niche market. You know, I know it's very unique, but all the other clinics in Manila are usually about 10 to 18% men. But I think what we've done is really what the strength of my practice is mostly with social media. The thing is that there are a lot of patients who are interested and they know about it, but if they don't know that you're doing it, they will not come to your clinic. So just as a tip or a suggestion, it's about marketing and social media as well. Anyway, yeah, so there you are. So now, sexy jaw or jawline augmentation has gained a lot of popularity, but are we doing it correctly? All right? So in my clinic, I did mention about our social media marketing campaigns, and as you can see, there are a lot of likes and comments and shares from these posts. And in my clinic, as you can see here, filler for the jawline is my top one filler treatment that I do. Mostly in men, a few female patients as well. But even if it's just two, but you can see here, thread lift, toxin of the platysma, fat melt of the neck, some of these are also related to the jawline, actually. So jawline is really something I love doing. So as I mentioned, jaw fillers are gaining popularity, but are we doing it correctly? Just to show you an example here, the filler is injected into the muscle, and every time she clenches her jaw, something protrudes. And that's because the thing is, your masseter muscle is almost strongly adherent to the bone. There's no deep fat there. So when you inject filler with a sharp needle to the, deep to the gonial angle, most of your filler actually, or all of your filler is in the muscle. Okay, so that's why every time they clench. And now, my secret, later I will show you how I prevent this. All right? Now, in as much as you can overfill the midface and the lips, you can actually overfill the lower face. And as you can see here, maybe for some nationalities or some cultures, they do like this. I know in Latin America, in Europe, they like this. But in Asia, do we like it? No, right? So everybody's like shaking their heads. So, no. So we have to be careful about that. Now, another thing, this filler migration. Now, I always say that filler will not walk on its own. It doesn't really migrate. As you can see here, there's filler below the jawline. But let me show you. So this is a video by Dr. Leone, an ultrasound expert. So someone is injecting with a needle on top of the temple or the zygoma. And you can see filler is migrating sidewards as you inject it. So meaning, as you inject your filler, you're already making it migrate. So it didn't walk on its own over time. And yeah, you see filler. And the same thing, the more filler you inject at the angle of the jaw, it would just spread sidewards. That's why you need to be mindful of the amounts of filler that you inject. Another thing, and maybe you've seen this video on TikTok or in social media, so filler injected, wrong layer, the wrong type of filler, so when he opens his mouth, the filler floats and it looks too obvious and unnatural. Although sometimes I tell my patients, you don't really open your mouth like that, no? Nobody really opens their mouth like that, unless you're doing some activity that we don't know. But the reason being is because you're injecting filler on the superficial fat layer. At a certain point, there's mobility of that area because of the jaw opening. Or you have a certain area that doesn't really move, but then as you move more medially, it becomes more dynamic. Another thing is fillers, you know, even if you have a high G prime filler, as you can see here, this is a very high G prime filler, but when you massage it, you press it, it breaks into pieces. The same thing as well, when you inject filler on the area and then you break it and you massage it, you can potentially spread it across. Of course, vascular occlusion is something where we don't want to happen. This is my actual patient, which happened in 2019. I was told before that the chin is the safest place to inject filler on until I meet this. And that's because you have your ascending mental artery, which is superficial or either subcutaneous or intramuscular. Now, along the angle of the jaw, your facial artery is deep. It arises by the bone, all right? And you can feel the notch, and then it becomes more superficial as it goes superiorly. So when you inject filler in this area, okay, if you're going to inject with a sharp needle to the bone, really stay at the angle. If you're going to use a cannula superficially, it has to be superficial. Because the deeper you are, the more risk that you're going to encounter the vessels, all right? Now, another advice I will give you is have the right product. And what is the right product? So for me, for the jawline, I have two kinds of filler that I use. So you want a stiff projecting filler, which is high G prime, and this is what I use for deep injections to the bone and also to the chin to give it projection. But I also need something superficial so that I can create definition, shape, right? But the high G prime, the stiff filler, I cannot inject superficially because you'll see what happened earlier. So, but I need something with good tissue integration, but can still project. So it's like a balance. You want projection, but it shouldn't over-project. And these are the different kinds of filler. I like, the one in the bottom is a very stiff. You can see the coarse granularity of the gel. Then these are ideal for the projections. But if you inject this superficially, it will become lumpy and obvious. So maybe this one or maybe the next one would be ideal for superficial injections. Now, again, it would depend on the behavior of the filler. Every brand would have different kinds of physical properties, and it's up to you really to test it. Now, I've been mentioning about projection, definition. What's the difference? What do we give our patients? When you say projection, you're increasing bigonial width, right? To strengthen the jawline, to make it more square and masculine. Bigonial width, for me, my standard, it should be close to or equal to the bizygomatic width. If your bigonial width becomes too wide, larger than your bizygomatic width, for me, that doesn't look very natural anymore. Maybe for Caucasian, it's okay, but for a lot of our Asian faces, we don't like that. Okay, actually, we even prefer sometimes the K-pop or the Korean look, right? So so from here versus K-pop, I like a hybrid between the two. All right? So again, avoid overprojection. Usually for my Asian faces, I use somewhere minimum for 2 syringes of filler up to 4 ml. For my Caucasian patients, my minimum normally would be 3 and up to 6 ml because I feel like Caucasian faces and skin have more space inside that you need to fill. And of course, they have bigger bone structures. Definition, when you say definition, you're creating definition so that the face would be separate from the neck. And that's where your superficial placements of filler would be nice. But you can also combine to create that definition because you lose definition as you age, you lose definition as you gain weight, okay? And so basically that's it. So then, you can also treat it, treat the fat, treat the sagging skin, and that's where your combination injectable will come in. Now, before I talk about combination, I want to talk about correct product placement. So this is my usual. So the stiff volumizer will be the blue one, and the superficial placement. I usually do an entry point by the jowl fat because that's just my entry point, but I will not put filler there. We're using a gauge 23 or a 25 or a 22 cannula. I would use that entry point to create some definition posteriorly to the jawline, and sometimes even in front of it on the marionette line, and also even to shape the chin. So another thing, so if you see this patient had filler, he opens his mouth, right? So I'll draw this line wherein I don't want too much filler in front of that line. So when I inject filler, imagine this triangle wherein the dark blue would be the peak or where the bulk of the filler is, and as I go down that pyramid, I have less filler. So you have a gradient that slowly disappears so that when they open their mouths, it doesn't become obvious. So this is that patient wherein I used filler for the jaw and the chin, and you can see more square and also improvement. But the magic happens that you can see more on the side. You see good projection of the chin plus better definition of the jawline. And as you can see, even as he opens his mouth, you don't see the filler floating. I believe I used a total of like 4 ml of filler for this patient, for chin and jaw. Now, combining is really very nice, but normally we use a lot of fillers for the jawline. But what if your patient comes like this? What if your patient comes like this? What if your patient comes like this? They come to me, I want sexy jaw. No? So then you need to think of other treatments, and I do mostly injectables. So toxin would be nice, number one, to debulk masseter muscles if it's big, or do intramuscular injections to the platysma to tighten that neck and to relax the depression of the platysma and the muscle. Lipolysis, if they have thick fat, if you do surgery or liposuction, you can. Me, I just do injectable lipolysis. And then threads would help tighten the skin. So what I normally do is I would tighten the skin above the jawline and below the jawline. And these is my simple algorithm. So almost every patient you can actually inject filler. You can even do it deep or superficial to create definition. And then depending on the condition of the skin, the thickness of the fat, the age of the patient, sagging skin, then you can combine. So take a photo so that you can have an idea as well. And of course, you can modify it based on your ethnicity, the culture, aesthetic taste of your patients. All right? Combining means you use less of one particular product and you address various layers so that you have better and more natural looking results. Rather than injecting more and more and more filler so that you can get your result, which I did when I was first starting to do filler for the jawline. I would inject, this definition is not yet there, I put more filler, and then I get the lump underneath. So that's what happens, these are the common mistakes that we all encounter. All right? So just to give you an example, the patient earlier, so he came to me, he's a 57-year-old Caucasian male. I said, I want sexy jaw. I saw from the US, he went to the Philippines. He was doing like medical laboratory and everything. I want sexy jaw. I'm like, I scratch my head, it's like, no. But then, so I did combination of thread lift. So this is immediately after threads. Right? And then when he came back 2 weeks later, I did some filler. So, it's nothing magic, nothing dramatic. It's not like surgery, but at least you see some definition and improvement. This is an even older male, 70-year-old male. So I did combination filler, thread, and toxin as well. Now, this is a young patient who I've met even in 2019. At first, I was melting the filler, the fat on his cheeks with the oxycolic acid, also doing toxin of his masseter to make his face smaller. And then, so this was him, like the K-pop era. And then I said, let's put a little bit of filler to create that jawline. And you can see the not too slim, not too square, just right. And then he loves it. But then throughout the years, so he comes back to the clinic. I usually maintain the toxin of the masseter because he wants his face small. And occasionally I would add a little bit filler. But then last year, I said, I don't want to add filler anymore because the more filler I put in, it's going to accumulate over time. So I did threads. I used multi-directional barb threads, 19 centimeter. I entered by the tragus. On top of the jawline, as I've mentioned, and then another one under the jawline to tighten that area. So I'm gonna show you a little quickly how it looks. So from under the jawline, I entered the platysma auricular ligament, so I tightened that as well. So this is, again, multidirectional barbed thread, PCL, PLLA with HA. And then after that, I do toxin of the masseter. So I can combine at the same time. Ideally, you do your toxin 2 weeks before, but in instances like this, then you can combine same day. But you do your toxin last. So here I'm doing the toxin for the platysma. And as you can see, even without doing fillers, just the toxin and the thread lift, you get that beautiful definition already. And this patient of mine, he simply loves the result. So this is the thread placement. But you can see when he posts in social media, it's always like at an angle. And he's one of our models for the Clinic for Sexy Jaw. In conclusion, jawline augmentation has gone popularity but needs to be done properly. Know your anatomy. It's about projection, definition, and correct proportions. Proper placement of your filler is key, and combine, because we do really need to combine. All right, and with that, thank you so much. Please do follow me. I do have my Injectors Academy also. I do training, so if you want to learn more how to do natural-looking results with your injectables, please do get in touch with me. Thank you so much.
Thank you, Dr. Cyril. Excellent presentation. Our final speaker, Dr. Daniel Widianto. Please, doctor.
Okay, hello everyone. My name is Dr. Daniel. Basically, I am an andrologist and aesthetic doctor from Indonesia. So today I will presentation of my clinical case about testosterone and transepidermal water loss in male patient. Okay, so maybe you already know about this book. So this book, Men Are From Mars and Women Are From Venus. For your information only, Mars and Venus is about 120 million kilometers apart, so it's very far away. So I think the message from this book is men and women is totally different, including in their skin characteristic. So where is the major difference between the skin in the women and in the man? The male skin is more thicker, more collagen, and also more oily compared to the female skin. And the next question is why? Why does male skin is different for the female skin? Maybe you already know the answer is about testosterone. Men have higher testosterone level compared to the women. And the next question is, what does testosterone do in our skin? So the first one is testosterone will stimulate the fibroblasts to produce more collagen. So that's why in male skin, 20% thicker compared to the female skin. And the second one, testosterone also stimulates the sebum production. So that's why male skin is more oily compared to the female skin. Because of this testosterone effect, male skin is aging differently compared to the female skin. Okay, for this presentation, I will focus on the sebum. So we know that sebum and sweat are the part of the hydrolipid film. It is a semi-occlusive layer on the skin that can support the skin barrier to prevent the transepidermal water loss. So, testosterone stimulates the sebum production. It means testosterone also contribute form the hydrolipid film. And it means testosterone also preventing or reduce the transepidermal water loss in male skin. But the problem is testosterone is decreased by the age. In men, after 35 years old, our testosterone is decreased 1% per year. And it will lead into the several symptoms that we call testosterone deficiency syndrome. And there is one condition known as late onset hypogonadism. So late onset hypogonadism is a clinical and biochemical condition in aging men characterized by a decline in testosterone levels. And this condition also leads in various specific symptoms. And this is the symptoms. The first one is decrease in sexual drive. The second one is erectile dysfunction, fatigue, anemia, decrease in muscle mass, maybe depression, memory issue, weak bones, osteoporosis, increase in belly fat, and increase the risk of diabetes and heart disease. So, how can we diagnose the late onset hypogonadism? Based on the recommendation of American Urology Association and ISSM or International Society Study of the Aging Male, to diagnose the late onset hypogonadism, we need the combination of the several symptoms that we call testosterone deficiency syndrome, and then the low testosterone level on the blood examination. We can say the testosterone level is low if the testosterone level below 346 nanogram per deciliter. And then for the initial screening, we can use the ADAM questionnaire. As you can see here, there are 10 questions that we can ask to our patient. The ADAM questionnaire is positive if our patient say yes in 3 questions or more, or if our patient have erectile dysfunction or decrease in sexual desire. If the ADAM questionnaire is positive, we need to check the testosterone level in the blood examination to diagnose the late onset hypogonadism. So, I have a hypothesis. In men with late onset hypogonadism, the testosterone level is low. And then the sebum production will be decreased, and it will affect the hydrolipid layer. And in my hypothesis, the transepidermal water loss will be increased. So what happens if transepidermal water loss increase? The first one is dry skin or cirrhosis. The second one is skin flaking and scaling, pruritus or itching, increased sensitivity, delayed wound healing, and maybe increase the risk of dermatitis and eczema. To confirm my hypothesis, I made a case study. So there are 60 male patients come to Dr. Sutomo General Hospital in Surabaya with testosterone deficiency symptom or testosterone deficiency syndrome. And then I measure testosterone level in the blood examination to diagnose or confirm my diagnosis with late onset hypogonadism. And the result is 16 men is diagnosed with late onset hypogonadism. And then 16 patients will be my study subject. And then I measure the transepidermal water loss using the thermometer on their forehead. All of the patients must wash their face and avoid using skincare maybe 30 minutes before the examination. And the temperature room was set around 20 until 24 Celsius degree to eliminate the external factor that maybe can influence the measurement. As you can see here, the transepidermal water loss are expressed in the gram per meter square per hour. And in my study, the transepidermal water loss of the patient was ranged from 17.2 until 50.8, with the mean 31 gram per meter square per hour. And it means the study subject have critical skin condition with high transepidermal water loss level. And this is the correlation analysis. As you can see here, this is a significant relationship between total testosterone and transepidermal water loss, with P 0.001 and R negative 0.853. And it means there is a strong negative correlation between the total testosterone and the transepidermal water loss. So the conclusion is the lower the testosterone level, the higher the transepidermal water loss. So it means this study is confirm my hypothesis. This is the summary of my study subject. You can see here from the background, study design, measurement, and also the result. And I have submit my study into the clinical paper. Maybe you can read the full article for more detail here. And the next question is, what can we do in this condition? So there are two concepts of treatment. The first one is primary treatment. We know that the main cause of this condition is low testosterone level. So we can do the testosterone replacement therapy. If we can increase the testosterone level, maybe we can improve the clinical symptom. And the second one is secondary treatment. We can focus on the skin barrier function. We can use the high molecular hyaluronic acid to improve the skin barrier function. Okay, let's talk about testosterone replacement therapy. So there are several ways to deliver testosterone in testosterone replacement therapy. Per oral, buccal, intramuscular, subcutaneous, and also transdermal. In Indonesia, the most common way is intramuscular injection. In my clinic, I usually use testosterone enantat and testosterone cypionate because it is a short-acting testosterone. We can use once a week with the doses around 200 until 250 milligram. And I think the short-acting is safer because if the patient had adverse effect, the adverse effect will be dismissed so quickly after we stop the injection. But I also use the testosterone andecanoate. It is a long-acting testosterone, especially for our patients that live outside the city. So this is the conclusion. So the first one is male skin is totally different compared to the female skin because of the testosterone. Male skin is thicker, contain more collagen and more oily compared to the female skin. But the testosterone level is gradually declined with age. If the testosterone level is decreased, the sebum production also decreases, and it will affect the hydrolipid layer, and it will increase the transepidermal water loss. In my study, I using a 16 male patient who diagnosed with late onset hypogonadism, and I measure the transepidermal water loss. And the result is there is a strong negative correlation between the testosterone level and transepidermal water loss. It means the lower testosterone level, the higher the transepidermal water loss. And I assume that if we can increase the testosterone level using the testosterone replacement therapy, maybe we can improve the clinical symptom. However, further studies needed to confirm my hypothesis. So that's all of my presentation. I sincerely appreciate your time and attention. Once again, thank you.
Thank you, Doc. That's very interesting. I actually, while you were doing presentation, I looked at my lab values of testosterone. But anyway, if you have any questions, you can either use the app, you can enter questions there, we can read it from here, or if you're brave enough, please approach our mic to ask questions from any one of us, your speakers. Questions?
Any question? I have one question to Dr. Dairy about biostimulation in men. So, in my practice, I work in Italy. I have some difficulty to invite my male patient to this kind of treatment. What about your experience, the adherence of male patient to this kind of procedure?
Well, I feel that in Asia, because of like social media,
Yeah.
that convinces, and we provide, especially for like reliable physicians, they provide before baseline and after photos.
Yeah.
Yeah.
But
So
they-
the posts are actually coming from reputable sources, and it is easy to encourage men.
Yeah, but in my country, men, they don't want to come back frequently. They want one procedure, one a year, once, and done.
Because the Italian men, they
Yeah.
always think that they are good looking already.
Well,
So-
it is true a bit,
Yeah,
no?
sure. Who knows? Thank you, thank you.
But that's true. I think like men normally we want one treatment and don't want to go
Yeah.
back too often, right? And that's what one of the things that I like about them. And when I do my injectables, I try to do as perfect as I can so that even if I don't see them,
Yeah.
they're happy.
And by the way, I also noticed that the partners of the women who are always in the clinic, when they see the results and then they request for similar procedures.
Yeah.
Yeah.
I have the contrary. I treat wives and then they bring husbands.
Oh, yeah.
I think that's the original. Even for me, when
Yeah.
it was starting, that's how usually the men are brought in through their wives. But now, because of social media, as Dr.
Yeah.
Johannes mentioned, men already know what they want.
Yeah, I have a comment regarding the replacement of testosterone. Even when there's some benefits, including the skin, there's some issues regarding psychiatric disorders, and also it increases the cardiovascular major events. So nowadays, it's even when there's some physicians doing it, the right levels and the amount of dosage of testosterone is still pending, and we need more data to say the patients to do the replacement. So it's important to advise that and to referral to an endocrinologist.
I have questions, Doc. When do you, from the age you said after 35, it starts to decrease, but when do you decide they need hormone replacement already or supplementation? At what level of decrease, or at what age would you recommend it?
Okay, I think the first one is the symptom. I think the most important symptom is the reduce in the sexual desire and the erectile dysfunction, because it's very specific for testosterone deficiency syndrome. And the second is the testosterone level in the blood examination. If the testosterone level below 340 something, I think I will do the testosterone replacement therapy. But if the testosterone level is about 500, maybe I will observation first, maybe 1 until 3 months, and then I will decide we go for the testosterone therapy or not. Something
Would you give it for, let's say, patient with good testosterone, let's say 356, no symptoms, but he wants to perform better, he wants to have bigger body, he wants to be more active at work, would you recommend it?
Okay. Okay, the first one I will explain to them the testosterone effect, negative effect, and then I will tell them that I cannot increase the testosterone until the supra level. Maybe I cannot increase until 1,000 nanogram per DL because it's very dangerous. If you want to inject testosterone for muscle building or something like that, in my clinic I don't do that because I think it's very dangerous and not for the health.
Sometimes the gym doctors, they inject
Yes.
it, no? Yes, question. The gym doctors now, they even inject peptides. The Dr. Jim, the Dr. Coach.
My question to Dr. Daniel, while testosterone may improve skin hydration and reduce the total sebum water loss, should we also anticipate the increased sebum secretions as its consequence, and how to prevent it?
Okay, in my experience, if you use testosterone replacement therapy, maybe in the first 2 until 4 weeks, maybe it will increase the risk of acne. Because the testosterone level is boost, something like that. But after 1 until 3 months, the acne will be decreased. It also happened to myself. And in my opinion, if you talk about the hydration, we cannot relate only on the sebum, because the factor that influence the hydration of the skin is many factors. Maybe doctor, do you want to add something?
The last.
I totally agree. It happens like the same phenomenon with the transmasculine body in a small level. So 1 to 3 months, a little flare-up of acne, it's usually mild, and we can use retinoids or peroxide, and that's all.
One last question. Do the trans men, do they have to how long do they usually maintain these drugs, the hormones? Do they reduce it? Is there any point that they can stop it?
They can never stop it. Sometimes they reduce it after 1 or 2 years, depending on how muscular they want to look like and the side effects. And so the idea is to continue use the adapalene or retinoid acid and see if it's enough to recover the acne. But I think the first 6 months are the worst. Then naturally the acne decreases.
Yes, thank you.
Yeah.
All right, thank you. Well, that ends the
Thank
session.
you.
Unfortunately, I know we have a lot of questions in our head, but if you have any questions, you can approach any one of us speakers. Thank you so much, Kapunakap.
Thank you.